So without wasting much time, let's get started with today's topic. The first thing that I want you guys to notice is that this is divided into 8 different kind of sections. Like there is bacteriology, virology, gram-positive, gram-negative bacteria, and there is different kind of sections. And in each section there are high yield topics. So there are 35 complete topics. There are not only 35. Like for example, in meningitis, there are 3 different topics covered. So this is how it is, and you can use it to solve most of the questions from microbiology. So at least you have to do this much if you are unable to revise microbio properly. So let's start with meningitis. The first thing that I want to tell you is CSF patterns and the organisms by age as well. So the first thing is bacterial CSF pattern. In bacteria, like we all know, bacteria likes glucose, so it will consume glucose. So glucose in CSF will get reduced, so it is less than 4.5 grams per deciliter or 45 milligrams per deciliter. And the protein is increased because it doesn't consume protein. Protein is elevated, and neutrophils are also elevated. So you have to remember what is elevated and what is decreased and what remains same. So that is how you will be able to tell if it is a bacterial meningitis, viral meningitis, or it is a listeria meningitis. And the next thing is about age-wise microorganisms. So in age-wise, the neonates are most commonly affected by group B streptococcus more than E. coli, more than listeria. If question mentions something like there is a 4-year-old child or in any age between 3 months to 5 years, then you have to remember that this is most common organism, that is Streptococcus pneumoniae. In adults also, Streptococcus pneumoniae is culprit of morely 50% of the times, but then it is followed by Neisseria meningitis, and then the least common is Listeria. So you have to remember this as well. If you are unable to remember it, then just write it down on sticky note or any foolscap and stick it on your wall and read it every day. You will remember it for sure. Or solve some questions and you will remember it. The next thing is about non-bacterial patterns. So the viral one, in viral one there are lymphocytes are involved. There is normal glucose and there is mildly elevated protein. And most commonly herpes simplex virus 1 is more commonly associated with it. And the next is about cryptococcus. So it is stained with India ink. So it is India ink positive, and there is cryptococcal antigen sensitivity, which is 95% of sensitive. The MCQ key point that I want you to focus on is that whenever there is mention of post-meningitis deafness in question, you have to think about Haemophilus influenza. Whenever the question mentions about petechiae and meningitis, then you have to remember meningococcus. And if it is about TB or anything related to TB, appearance of CSF in TB, then there is very low glucose and there is high chloride, and of course it will be turbid. The CSF will be turbid. Let's move towards the next topic, that is hospital-acquired infections, also called as nosocomial infections. The most common is UTI, urinary tract infection, ventilator-associated pneumonia, or surgical site infection, or bloodstream. So you just have to remember that which one is common and what is the most common causative organism. So for example, most common hospital-acquired infection is UTI, and the most common cause of most common hospital-acquired infection is E. coli. So you have to remember these things. And same about ventilator-associated pneumonia, surgical site infection, and bloodstream infection. The risk factors and clues that you have to remember is that whenever the question is about methicillin-resistant Staph aureus, then you have to remember that the most common risk factor is intubation and prior use of antibiotics. That's why physicians are completely right about this thing, that we shouldn't use antibiotics as soon as we think that someone is coughing, so the person or the patient might have bacterial infection, and we shouldn't prescribe azithromycin or similar antibiotics straight away. So that causes antibiotic resistance, and this is one of the risk factors for methicillin resistant Staph aureus. Then there is Pseudomonas. So the risk factor is ventilator, like prolonged ventilation, because if the patient is on ventilator for a couple of months, then there is high chance that he might get Pseudomonas infection, and water source infection as well, like if the water source is polluted. The next is about Acinetobacter. The risk factor is ICU stay plus multi-drug resistance. So if the patient has drug resistant to multiple drugs, then there is high chance that Acinetobacter will be causing infections in this patient, because it is one of the common organisms in hospital. And the last one is Candida, but it's not least, because it is associated with central line, which is very common procedure in hospitals. And there is also like broad spectrum antibiotic resistance, so which is involved in Candida infection. So that is what you have to remember about nosocomial infections. And the single best answer, if you are asked a few questions in MCQ, then if the question mentions about green pus and ventilator associated pneumonia, then you have to answer it as pseudomonas. And if the mention in the question is about catheter or yeast, then you have to answer candida. And if there is anything about surgical site infection like this one, then it is Staph aureus. And methicillin resistance, that is something that we have to check, because staph is most commonly nowadays, like there is antibiotic resistance, which is something taking concern of physicians. Let's move towards the next topic, that is fever of unknown origin. There are different types of fever, like there is hemorrhagic fever, enteric fever, rickettsial fever, leptospiral fever, and other. But in our exams perspective, the FMGE exams perspective, the like most common one is enteric fever, that is caused by Salmonella typhimurium. So there are two different types of typhi. The first one is S. typhi, and that is 90% of the times the causative organism. And the next one is about paratyphi. So like there is a test, that is Vidal test, that we do to check if the patient is having typhoid or not. And the thing that I want you to consider here is that there is a step ladder pattern of fever. The fever does not reside. If the fever persists for 2 to 3 weeks, then we have to think about typhoid, and that is what we do. Like the Vidal test is what we do. And there is relative bradycardia, which is one of the common symptoms in the patient. There can be rose spots on the trunk, less than 5% area is involved of the trunk, and there can be splenomegaly. The next is about vector-borne diseases, vector-borne fever. The very common is dengue. As we all know, it is very common in our country, and common things are asked commonly, rare things are asked rarely. This is something what I heard from my faculty when I was studying myself. So yeah, you have to remember this. Dengue is a common topic, so you have to remember all the facts that are related to dengue, because yeah, it is a common topic, so it will be asked commonly. So there is a breakbone fever. Breakbone is something like it doesn't actually involve fractures, but the thing that it involves is that there is a severe joint pain which is related to dengue. So that's why you have to remember that breakbone fever is there. Then there is thrombocytopenia. Thrombocytopenia means a decreased platelet count, that is less than 100,000, and hematocrit is increased. So I would like to ask you a small question here. What makes the hematocrit increased in case of dengue fever? You can answer me in the chat box, like in comment section, and if you are right, then nice. If you are not right, then I'll tell you guys in the comment section. And DHF stands for dengue hemorrhagic fever. So the next one is Plasmodium falciparum, and it is something known as cerebral metabolic acidosis, kidney, and anemia. So that's why it is written as CMNA, because this is a short form and you can remember it like this. Then there is rickettsial and leptospiral fever, and about this you have to remember that if it is rickettsial, then the rash appears on the trunk, same as this, but here it is only less than 5% or 5%, but here it is more than 5%. And the rash can spread to peri as well, like palms and soles and other things. And Weil Felix test is that we do for rickettsial fever, and that is positive in case of rickettsial fever. In leptospira, there is a biphasic fever, there can be jaundice, and there is also pulmonary hemorrhage in most of the cases, so the prognosis is usually bad. So in one liner, what you have to remember is whenever there is a MCQ, and if the question or MCQ mentions something like step ladder pattern or rose spots, you have to think about enteric fever, and the common organism is S. typhi. So typhoid is what you have to think about. The next is about thrombocytopenia. If the question mentions anything about platelet count is decreased and it is less than 100,000 and something like that, and patient is having joint pain and something, or breakbone fever is there, then you have to think about dengue. And if there is a rash on palms or soles and something is mentioned like this, and Weil Felix test is given positive, then you have to think about rickettsial infection. So this is all about fever of unknown origin. Let's move forward towards diarrheal pathogenesis. The very first thing that I want you to consider is Vibrio cholerae. Vibrio cholerae, whenever there will be question about it, they will be mentioning in the question about rice water stools, because it is very specific and many a times it is repeated. Rice water stools, Vibrio cholerae. The patient is febrile and the culture they use is TCBS. They can also ask this question because this was also there in recall GTs and mock tests, because this has been a previous year question. So TCBS stands for thiosulfate citrate bile salt culture. So you have to remember this as well. The next is about Shigella. So whenever there will be question about Shigella, they will be mentioning symptoms of dysentery. We all know that dysentery means there is passage of blood with mucus whenever the patient goes to pass stools. Then the media is PM enriched, and there can be invasive type of diarrhea in it, the inflammatory type of diarrhea, and the agar they use is SS agar. The next is about entamoeba. In entamoeba, there are RBCs present, there can be trophocytes, there can be liver abscess in the patient, and the immune hemagglutination assay serology, that is IHA, is what we do to diagnose entamoeba diarrhea. The next thing is about Clostridium difficile. We all know that there are pseudomembranes which are present in case of C. difficile, and whenever we give patient very vigorous antibiotic therapy, then there is very high chance that the patient might develop Clostridium difficile diarrhea. And the toxin ELISA is what we do for diagnosis of C. difficile. The last one but not the least is Giardia, and we all know that Giardia is having fallen leaf motility. So this is something that you can relate or remember whenever there is something related to it. The next thing that I want you to know is that whenever there will be a question which mentions rice water tools and no fevers, then it is cholera. Whenever there is a blood plus mucus or tenesmus means there will be abdominal cramps and pain while continuous feeling of passing of stool and urine, like to empty the bowel and bladder. But even if the bladder is empty or bowel or stools are already passed, then also the feeling will persist, and that is what tenesmus is. It is related to Shigella, and that is what known as dysentery because there is blood as well. And the last but not least is post antibiotics exposure, whenever there is a severe or vigorous antibiotic therapy, and when there is a mention of pseudomembranes, then the thing that you have to think about is Clostridium difficile. Let's move forward towards the respiratory pathogens. In respiratory pathogens, the two things are very important. The first one is CAP and the second one is TB. CAP stands for community acquired pneumonia, and TB, we all know that's tuberculosis. The first one that I want to talk about is CAP, community acquired pneumonia, which is divided into typical and atypical things. The typical one is basically related to the acute and lobar pneumonia. The streptococcus pneumonia is the most common culprit of this disease or condition. Then there is Haemophilus influenzae, and the thing that they will be mentioning in the question is purulent sputum. They can mention the color of the sputum, that gives you an idea or hint to distinguish further. But the thing that I want you to focus on is streptococcus pneumonia is the most common organism for typical community acquired pneumonia. And in atypical cases, the onset is insidious. There can be dryness. The common cause is mycoplasma, chlamydia, and legionella. In TB, there are different forms of TB. Like there are three most common forms. The first one is primary TB, then there is reactivation TB, then there is miliary TB. In primary TB, children less than 5 years are more affected. Then there can be hilar nodes involvement, and gone focus is what we see in it. The second one, that is reaction TB, it involves adults as a patient, and there is apical cavitary lesions which we see in this condition. The next one is miliary TB, and there is hematogenous spread, there is dissemination, and there are multiple nodules. That's why it is known as miliary TB, because there will be small lesions which we can see. The next one is about the drug resistant. So there are two types of TB, there is multi-drug resistant TB and there is extensively drug resistant TB. Multi-drug resistant is denoted as MDR-TB, and the extensively drug resistant TB is denoted as XDR-TB. So in multi-drug resistant, the TB is only resistant to the isoniazid and rifampicin. INH stands for isoniazid and RIF stands for rifampicin. So in extensively drug resistant, along with the isoniazid and rifampicin, it is resistant to the fluoroquinolones as well as injectable resistance. So what I want you to focus on is that whenever there will be question and the question mentions rusty sputum or there is lobar involvement or anything like that, then you have to consider the pneumococcus infection. If the question mentions something like apical cavities and everything, then you have to consider TB reactivation. And if there is something called as gene expert, then it is used for rapid TB assay, and there is also a thing called as rifampicin resistance. So that also we can come to know if we do gene expert testing. So the next thing that we are going to start is HIV CD4 counts. Like this is something that you have to read very nicely and by heart it very nicely, because the thing is that whenever I used to give a GT or recall test or any custom module or anything like that, then there used to be at least 1 or 2 questions from this topic, because this is related to one very high yield topic, and that is HIV AIDS, that is acquired immunodeficiency syndrome. So the CD4 count, if it is less than 200, then it is PCP. PCP stands for pneumocystic gyrovascular like a pneumonia. Then there can be symptoms like dyspnea, there can be decreased partial pressure of oxygen, and there can be bilateral infiltrates as well. The next thing is about CD4 counts. If it is less than 100, then it is most likely the infection related to toxoplasma, because that is the highest opportunistic infection in that thing, if the CD4 count is less than 100. And there can be ring enhanced brain lesions in this. You can see this here as well, because toxoplasma, ring enhanced brain lesions, this is one liner. This is just one liner, what is important for the exam. If you don't want to read these as whole, you can read it like this. Then the next thing is, if the CD4 count is less than 50, if the CD4 count is less than 50, then it is related to cryptosporidium, that can cause diarrhea. If the question mentions something like the patient is having diarrhea, you have to remember it is cryptosporidium. If the question mentions something like retinitis, you have to think about CMV, cytomegalovirus. And if the question mentions something about meningitis, then it is most likely cryptococcal meningitis. In the context of India, OI stands for opportunistic infection. So TB is the most common opportunistic infection in our country, and because of this only, you can expect at least 1 or 2 questions from TB in your upcoming FMGE exam or NEET PG exam, because this can come in any exam that is conducted in India. And MAC stands for Mycobacterium avium complex. So that is less common in India as compared to the Western countries. So yeah, that's all about this topic. Let's move towards the next topic, that is IAP vaccinations. The next topic is very important topic, that is STI, sexually transmitted diseases or infections. There are 3 most common and high yield topics that I have for you from this topic. The first one is syphilis, second one is gonorrhea, third one is chlamydia. So the very first one is syphilis. There are 2 types of syphilis. The first one is primary syphilis, the second one is secondary syphilis. The primary syphilis, basically it is a milder form. There are painless cankers and the dark field microscopy is positive. In secondary form of syphilis, there are rashes which involves palms and soles, and oral mucositis is also there. So this is how you can differentiate between these 2 forms of syphilis. Then there is a diagnostic test like RPR, and there is also VDRL. VDRL stands for Venereal Disease Research Laboratory titers, and those titers are matching these research laboratory values. So that is how we test for syphilis. Then there is also FTA ABS assay. FTA ABS assay stands for Fluorescent Treponemal Antigen assay. You don't have to remember the full forms, but at least you should know what are the diagnostic tests that we do for syphilis. And this assay remains positive for lifelong. Like it doesn't resolve with age or condition or treatment or anything like that. And the treatment for this condition is benzathine penicillin, and we give it as a single dose in intramuscular form. The next thing is gonorrhea. In gonorrhea, the positive organism is Neisseria gonorrhoeae. That is gram-negative intracellular organism, and it is Diplococcus. Like there are 2 circles, the shape. Then in men and women, it causes different symptoms. In men, that is acute urethritis, and in women it is cervicitis, and it is often asymptomatic in women. That's why it becomes ignored, like they don't know that they are having gonorrhea and anything like that, but there is discharge from it. So that's how they come to the clinic, and then we do diagnostic tests, and then we prescribe them ceftriaxone 500 mg intramuscular single dose. So that is the treatment of gonorrhea. And the very last but not least is chlamydia trachomatis. So it causes lymphogranuloma venerum. The short form is given here, LGV. It is an obligate intracellular organism, and there are 2 different variants of this organism, that is L1 and L2. This is L2, it's not L3, so you guys can correct it, or there is not even a need to correct it, because they will not be asking this much details like what are the forms and all those things. The next is about diagnosis. So the diagnosis is NAAT. We do NAT, and that is a form of PCR, and it is highly sensitive for chlamydia trachomatis, and the treatment for it is doxycycline. So you don't have to remember for how many times we give in a day, for how many days and all that stuff, but you have to remember the symptoms, the name of the drug that is used to treat it, and also the form of the organism, like if it is obligate intracellular organism, or what are the shape, what is the shape of the organism, and all that stuff. So let's move towards the gram positive section. The very first thing that we have in gram positive section is Staphylococcus aureus or Staph aureus, and MRSA, that is methicillin resistant Staph aureus. This is very high topic because Staph aureus is most asked bacteria in recent exams, like let it be INISET or FMGE or any other exam. So this is the most focused organism, so that's why you have to remember all the information that is related to this bacteria. The key features are it is coagulase positive, catalase positive, the golden colonies are found when we culture it, and there are grape-like clusters. Protein A is something that is related to Staph aureus that you have to remember, because in the cell wall there are different kind of chemicals, so protein A is one of those. Then there is also PBL toxin, that is necrotizing pneumonia toxin, and there are also enterotoxins as well. So these are the key features that you can remember, because these are the key features that will be mentioned in question by examiner. So this is how you will remember or recognize that this question is referring to Staph aureus. The next thing is about MRSA resistance. The most common thing that you have to remember in MRSA resistance is MIC-A gene. The gene is responsible for beta-lactam resistance, and that is the reason we have vancomycin, linezolid and daptomycin to treat MRSA bacteria. MRSA simply stands for methicillin resistant Staph aureus. We all know that MRSA was there in nosocomial infection, the hospital acquired pneumonia. When we studied, there were two categories, the typical one and atypical one. So this is the reason that we use these antibiotics, because these antibiotics don't have the resistance, these MRSA don't have resistance towards this bacteria, these antibiotics as of now. So that's why I use them. The diseases that are caused by Staph aureus, the skin diseases are impetigocellulitis and abscess, and the systematic diseases are bacteremia, endocarditis and osteomyelitis. There is something more that I want you to remember. In this case, MRSA, as we all know, that Staph aureus causes native valve endocarditis. But there is also one more organism from this same family, the Staphylococcus epidermidis, and that causes early valve endocarditis. Early valve means less than 1 year after valve replacement. Like if the endocarditis is caused within 1 year, then the causative organism is Staphylococcus epidermidis. But if it is a native valve endocarditis, then the organism that is causative for that case is Staph aureus. So this is what you have to remember. And if it is later than 1 year, like for example 1 year, 3 year, 5 years, 6 years, 10 years, or any time frame after 1 year, so that for that cases the causative organism is Staph viridans, and that is something related to BDS, like the dental procedures. Whenever there will be dental cleaning or something related to dentists, then the bacteria goes down and then it travels to the valves of the endocardium, and then it causes endocarditis. But that is what after 1 year. But within 1 year, if there is endocarditis, then it is because of S. epidermis. This you have to remember. And one more thing is that here you guys can see that this is coagulase positive, but there is one more thing that distinguishes this Staphylococcus family further, that is novobiosine sensitivity. So in novobiosine sensitivity, the one that is sensitive to it is S. epidermidis, as we all discussed right now. But there is one more organism, that is Staphylococcus saprophyticus, and that is related to UTI. For example, in nosocomial infections, we studied something about UTI. The UTIs are the most common nosocomial infections or hospital acquired infections, and the most common causative organism was E. coli. But whenever there will be mention of honeymoon or something like the couple is just married, then they went and traveled to some destination and then they came back and now the female is having burning sensation while urinating and all that kind of stuff, the most common causative organism will be S. saprophyticus. So you have to remember this as well. So the next thing is about Streptococcus pyogenes. It is a group A Streptococcus, also known as GAS. We discussed about group B Streptococcus, that is GBS, in hospital acquired pneumonia and all that stuff. So now we are going to discuss GAS. The virulence factors are M protein. As we discussed here in Staph aureus, the virulence factor was protein A, but here it is M protein. That is the cross-reactive protein with myocardial cells or cardiac myosin. So that's why it is important from exams point of view. Then there is also hyaluronic acid capsule in the virus. That is one of the virulence factors. And there is also streptolysin. So you have to remember these virulence factors. The next thing is about acute condition of the disease. So that causes pharyngitis, which is most common. It can also cause scarlet fever, and it can also cause skin infections. And there is a sequel that whenever there is this disease, then it is in association with the rheumatic fever. In rheumatic fever, the patient might present with cardiac symptoms like carditis. There can be polyarthritis. There can be chorea, like a sudden onset of movements, uncontrolled movements can be there. Like we all know about Huntington's chorea and all that stuff. So this is that chorea that can be there like after 2 to 3 weeks after this infection. And there can be also post streptococcal glomerulonephritis, that is PSGN, and it is after 1 to 2 weeks of this infection. So from exams point of view, we have to remember that if there is a sore throat, plus if there is a mention of M protein or hyaluronic acid capsule or streptolysin or anything that is like if they mention that there is a protein that cross reacts with the cardiac myosin and something like this, then these are the risk factors, and these all things points towards Streptococcus pyogenes. So you have to remember this. And the ASO titer indicates there is something called as ASO titer, that is indication of the prior infection. Then the next bacteria is Streptococcus pneumoniae. We already discussed about community acquired pneumonia, the CAP thing, and there were two types. If you guys remember, there was a typical and atypical one. So this is the culprit. This is the organism that causes pneumonia. The identification of this organism can be like there is alpha hemolytic chain, there is also optochin sensitivity, and there is bile solubility with respect to the characteristics of Streptococcus pneumoniae. There is also a shape about the organism. It is lancet shaped Diplococcus, and there is also polysaccharide capsule. There are 98 serotypes. You don't have to remember how many serotypes are there, but you have to remember the lancet shaped Diplococcus structure of the organism, because this is what they mention in the question. The questions that come from such topics is like for example, if there is a clinical question, then the examiner might explain something like there are these symptoms and the organism was cultured, and what the examiner observed is that there is a lancet shaped diplococci. So what is the main causative organism? So you have to remember that the lancet shaped diplococci is Streptococcus pneumoniae. Then with respect to the diseases, as I already told you, there is something called as CAP, the community acquired pneumonia. There is a rusty sputum in that, and there can be lobar consolidation. Meningitis, if there is a meningitis because of Streptococcus pneumonia, then it can be highest prevalence in case of patients who are more than 40 years old, and the patients who had their spleen removed. There is a splenectomy done on the patient because of any reason. So the patient becomes immunocompromised. So that's why this happens. And otitis media, sinusitis, and bacteremia are also the diseases that are associated with Streptococcus pneumoniae. The prevention of the disease can be done by there are vaccines. There is PCV13 vaccine, the conjugate vaccine. There are immunogenic vaccines, and the immunogenic infants need this prevention. Then in case of adults who are more than 65 years old, there is a PPSV23 vaccine, that is a polysaccharide vaccine. So you have to remember this as well. Let's move towards the next topic, that is group B Streptococcus. So GBS, we already saw this in the previous topics, but still we are going to cover this in shortcut. So in neonatal diseases, there are two types of diseases. The first one is early onset, the next one is late onset. The key information that you should remember from this slide is that if the pregnant woman is mentioned in the question, and if there are colonies of group B Streptococcus, then that is a pediatric indication, like Indian Academy of Pediatrics indication, and the neonatal meningitis is related to GBS, like group B streptococcus. So these things you have to remember. This is not much important, this Indian Academy of Pediatrics, but the more important thing is about pregnant woman. There is a mention of timing, that is less than 72 hours or more than 4 to 90 days, and meningitis and all these things. So you have to remember those simple things. The next thing is about C. diphtheria. C. diphtheria is known as Chlorinia bacterium diphtheria. This is more important because this has been repeatedly asked in recent FMGE exams. The exams, when I say recent FMGE exams, I mean the exams from 2023 to 2025's July exam. That is my attempt. The July one was my first attempt. So yeah, 2023 to July 2025. So this was a high topic, so that's why I have included it in this. So the pathophysiology is very simple. That is, lysogenic phase carries toxin gene. Then there is a diphtheria toxin that inhibits elongation factor 2, that is also known as EF2 in shortcut, that blocks the protein synthesis or decreases the protein synthesis. So this is the pathophysiology of C. diphtheria. The clinical features are gray pseudomembrane is there in throat or nasopharynx. That's why the doctor, the clinical scenario can mention something like the doctor tested the patient, the clinical examination, there was gray pseudomembrane in patient's throat or nasopharynx. What can be the most likely organism causing this condition? So I have to remember the gray pseudomembrane indicates towards diphtheria. So this is how you get hints from the question or examiner. The next thing is about myocarditis. There can be arrhythmias, there can be neuropathy related to cranial nerves. The treatment is simple. Treatment can be diphtheria antidoxin plus antibiotics, and if there is possibility, then we can also give patient a DPT vaccine that contains inactivated toxoid. So for the MCQ purpose, you have to remember that if there is a gray pseudomembrane plus there is no fever, then the elongation factor 2 inhibition, if anything of this is mentioned in the question or MCQ or clinical scenario or anywhere else, you have to point it towards Clostridium diphtheria. Let's move towards the Enterobacteriaceae family. There are a few things in that. The first one is E. coli strains. E. coli is more important because it is the most common organism that is responsible for the most common hospital acquired infection, that is UTI, that is urinary tract infection. And you guys can let me know in the comments which was the organism that was responsible for the UTI in case of honeymoon couples. I already told you the name of the organism. You can write it in the comments. The next thing is about Escherichia coli, the pathogenic strains. There are few pathogenic strains, like there is E-Tech, there is EH, like EHEC or EH or something like that. Anyone can produce anything, like pronounce anything. And then there is UPEC strain. So the very common one for us is E-Tech, that is enterotoxin. The EHEC is hemorrhagic E. coli, something like that, that is related to Shiga toxin. So O157 is to H7 is the main strain, and that is hemorrhagic. As I told you, H stands for hemorrhagic and E stands for T stands for travelers. So that is for travelers diarrhea. This is for hemorrhagic colitis and hemolytic uremic syndrome. And there is also something called as uncomplicated UTIs. So that is why there is UPEC, and it is for the 80% of the cases that are uncomplicated UTIs. The antibiotic resistance in these cases is for ESBL, that is common. The resistant to the third generation cephalosporins, beta-lactam inhibitor resistance, these all kind of resistances are there in case of E. coli. That's why the use of antibiotics is strictly monitored nowadays by healthcare practitioners. And then there is also CRE, carbapenem resistance, that is rare, but that is also the serious cause of concern for nowadays. So the exam purpose, you have to remember that if there is a clinical history of travel in case of patient, then you have to remember that strain is E-Tech. And if there is a history of hemorrhagic stools like Shigella, like dysentery and everything like that, then you have to remember the strain is EHEC. And if young woman plus UTI is mentioned, then that is uncomplicated UTI, that is for the UPEC strain. So let's move forward towards the Salmonella typhoid. So the things that we do for diagnosis and treatment, the very first thing is blood culture. Whenever you see any question, then don't jump towards the fluorescent assay and fish and all those VCR, NAT, all those fancy things. First of all, step by step, we have to think about the clinical scenario. So the very first thing we do for this condition, that is typhoid, is blood culture. Then we do stool culture. Then we perform Vidal test, though it is not that much reliable, but still we do it for cross-reactivity testing. And then for the treatment, we prescribe fluoroquinolones. So the resistance is emerging in India nowadays. Like, as I told you, the antibiotics are being used vigorously by a normal population. But the complications that the ileal perforation can be there, then can be encephalopathy, there can be myocarditis as well, and chronic carrier state has like a 1 to 5% risk of infection. So these are the things that I want you to remember about typhoid. These are the specific things. The next is about Shigella dysentery. Dysentery means mucus and blood that is passed out while passing stools. So that is what is dysentery. We already read about Shigella, like E. coli, in the E. coli, this E. coli strains, but now we are going to discuss extensively about Shigella. The features that I want you to remember is that it is non-motile, unlike Salmonella typhimurium. Then it is invasive, like the dysentery-like features are there. As I told you, there is a blood and mucus passed down along with the stools. So that is dysentery, the blood, mucus, and there are also polymorphonuclei in the stools. The Shigella sonnei is 50% of the times culprit. Then there is also flexinary, that is endemic, and there is Shigella dysentery that is rarely involved, but it has Shiga toxin. So in case of Shigella, I would like to tell you some more details, because this is the topic that is asked multiple times in recent exams, let it be NEET PG or FMGE. So that's why I want you to focus just for 1 more minute, and then you can have a break maybe if you are tired. So there are 3 toxins. The first one is enterotoxin, the second one is exotoxin, and then there is Shiga toxin. So as I told you that there is E. coli that has EHEC, like the Shiga like toxin is there. So in this case as well, there is some specific infectious dose. For example, if there are bacilli, from 10 to 100 bacilli are there in patient's body, then they have the potential to cause disease. So the infectious dose of Shigella is 10 to 100 bacilli. So this is what I want you to know. The next thing is about clinical features. The abdominal cramps can be there. There can be bloody or mucoid stools. There can be tenesmus. Tenesmus refers to the abdominal cramps whenever the patient has a feeling of emptying the bowels. Even if the patient already had passed the bowel movements, still the patient gets the feeling that the bowel is not completely empty, and there is a urge to empty the bowel, and there are also continuous abdominal cramps. So that is what is there. Then there can be also risk of seizures in children. The next thing is about treatment. So for treatment, we use fluoroquinolones, or we can also use ceftriaxone if the bacteria is resistant, if it is not getting treated by the fluoroquinolones. And the next thing is about the prevention. We have to avoid the anti-motility agents. So that's how we can treat Shigella or dysentery. The next topic that I want to cover is Vibrio cholerae. In Vibrio cholerae, the pathogenesis is very simple. There is a cholera toxin. As we all know that there are bacterial toxins, so this is also bacteria, so there will be a toxin. The shape is comma shaped because we all know it is a Vibrio. The thing that I want you to focus more on is this rice water stools, because whenever in past exams, whenever there was a question about Vibrio cholerae, there was a mention of rice water stools or rice gruel stools. So this is something that will be indicative of Vibrio cholerae in your exam. It is painless, unlike Shigella, because it was painful, there was tenesmus. Then there is a massive 10 to 20 liters per day diarrhea. So that is how severe it is, and the patient gets completely dehydrated, and this can be fatal at times. So that's why it is very important to diagnose and treat it at earlier basis. The next thing about the disease is about rapid dehydration. As I already told you, there is hypovolemia and there is electrolyte imbalance as well. So we have to give the patients ringer lactate along with the other electrolytes. The next thing is about the fever. There is no fever in Vibrio cholerae. We already discussed this in previous section, so I won't be focusing on this much more, but this is what distinguishes it from the bacterial dysentery. The treatment for Vibrio cholera or cholera is that the fluid replacement therapy, and we can also use tetracycline, doxycycline to reduce the shedding. The next disease or bacteria that we are going to discuss is Klebsiella pneumoniae. The features are it is mucoid, non-motile, and this is oxidase negative bacteria. There is also large polysaccharide capsule around it, and that is the virulence factor of Klebsiella. Also, there is a ESBL that is common in India. This is the strain, or you can also say variant. The disease, there is also community acquired pneumonia. We already discussed community acquired pneumonia, but we didn't discuss Klebsiella. So it is a lobar consolidation. There are current jelly sputum, and it is more common in alcoholics or COPD patients. Then there can be a liver abscess. It is a spontaneous disorder. There is no history of GI surgery, and there can be a history of cirrhosis or diabetes in such patients. There is a history of hospital admission, because this is one of the hospital acquired infections. So there can be ventilator acquired pneumonia or urinary tract infection history, and the treatment is simply third generation cephalosporins if susceptible, and we can also use carbapenem for resistant strains. So this ends our section of Enterobacteriaceae, and then we are moving forward towards the non-fermenters. So in non-fermenting organisms, the very first one is Pseudomonas aeruginosa. That is essential when we are studying ventilator acquired pneumonias. We already studied the community acquired. Now this is ventilator acquired, and this is most commonly seen in the ICU patients who has prolonged stay in hospital and who were on ventilator, because there is a positive pressure ventilation and the air is continuously pushed inside. So that is how the bacteria goes inside, and there is a numerous amount of infectious strains that are injected along with the ventilation that causes these features. Which features? These features. So the features are oxidase positive. The Pseudomonas aeruginosa is oxidase positive. It is what differentiates it from the Enterobacteriaceae family. There is also green pigmentation. There is also pyroidin pigment involved in this condition. There can be sweet smell, this can be a feature of this Pseudomonas aeruginosa, and there is a biofilm former. Then the virulence factor is exotoxin A. There is also something which inhibits the elongation factor 2 and causes disruption in the protein synthesis. There can be involvement of the elastase enzyme as well as flagellum. So these are the virulence factors that you have to remember. It is not that important in case of Pseudomonas aeruginosa. And the next thing is about the disease. This is more important. So you have to remember that it is the major contributor towards the ventilator acquired pneumonia, that is majorly nosocomial, that is hospital acquired. The chronic lung infections can be there. There can be also burn or wounds history. Otitis externa and osteomyelitis are the conditions which are associated with this condition. Treatment, we can give the patient the colistin. Colistin is a polymyxin E, and it is not the first line treatment. The first line treatment is anti-pseudomonal beta-lactams plus anti-pseudomonal. The treatment is anti-pseudomonal beta-lactams plus aminoglycosides combination. So we have to give the combination therapy here, and the colistins we can give, but that is not the first line treatment. So they can ask you a question like there is a patient who is having prolonged ventilation, and now he has Pseudomonas pneumonia. So what can be your first line treatment? First line treatment is always combination therapy of anti-pseudomonal beta-lactams plus aminoglycosides. The next bacteria that we are going to cover is Acinetobacter MDR, multi-drug resistant. It is a ICU threat. The features are oxidase negative variant. Then the features are it is oxidase negative. It differs this from the Pseudomonas that was oxidase positive. This is also gram negative Coccobacillus, and it also forms a biofilm around it. So these are the things that you have to remember about features. The next is about risk factors. There can be a mechanical ventilation. As I already told you, this is a ICU threat. So if the patient is on prolonged ventilation, then there is a risk of Acinetobacter pneumoniae. Then there can be a risk when the patient has central lines, wounds, burns, ICU stay, prior antibiotics, and all these things are risk factors. Resistance is high because nowadays many patients are using antibiotics like they are go-to drugs, but they are not. They are the prescription drugs, and you shouldn't use them without prescription. So this kind of irresponsible behavior is causing high antibiotic resistance nowadays. There are multi-drug resistance and extensively drug resistance forms. Carbapenem resistance is also noted by some of the researchers in India, and also for the treatment we use colistin monotherapy. Colistin we also used in Pseudomonas, but it was a last line therapy. It was not a first line therapy. Here you guys can see. Let's move towards the next bacteria, and that will end our this section of non-fermenters. So the last one is Haemophilus influenza. This is something that is very common condition in India, so that's why you have to study it. It was not asked in recent exams, but still it is one of the most high topics, so that's why it is included in this session. The features are, it requires X factor, that is heme, plus V factor, that is NAD. So this is the reason we use the chocolate agar, or we can also use the Staph aureus, because Staph aureus is hemolytic, and when the heme is broken down, then it gives X factor, which is required for it. So whenever we want to culture Haemophilus influenza, we will need something that is hemolytic, some bacteria that is hemolytic, and the hemolytic bacteria is Staph aureus. So this is the reason we use that when we are culturing it. So you can remember this thing. It's just an extra information. You can remember it as a story if you want. It is encapsulated. Then the diseases are meningitis and epiglottitis, pneumonia, otitis media, and all those things. Meningitis is mostly in children, and the post-meningitis deafness is more commonly observed in Haemophilus influenza infection. So they can frame a question on this. Post-meningitis deafness is associated with which bacteria? So Haemophilus influenza. And then for prevention, there are vaccines. Conjugated vaccine is there, and 90% prevention rate is there. So for exams point of view, I already told you that they can ask which bacteria is used for hemolysis purpose, or the post-meningitis deafness is associated with which bacteria. It is Haemophilus influenza. This ends our discussion with this section. Let's move towards the next section, that is Mycobacteria. In Mycobacterium tuberculosis, the features that you have to remember are the doubling time is very slow, that every 15 to 20 hours it doubles. Then it is also obligate aerobe. This is something that will be mentioned in the question, like if it is a clinical question, they will mention what kind of aerobe is it, like it is obligate aerobe or anaerobe, what kind of organism is it, and then they will ask you to recognize the organism, or then they will ask you to name the stain that is used to stain it. There is a mycolic acid that is in the cell wall, so that's why it is an acid fast bacilli, and Zale-Nielsen stain is what we used for it. The next thing is about the forms of the TB. There are 3 different forms of the TB, and these 3 forms are the primary TB, then there is reactivation TB, and then there is miliary TB. The primary TB is common in children, reactivation TB is common in adults, and miliary TB can happen to anyone, and it is an acute hematogenous dissemination, so it is a more fatal form. The drug resistant, there are 2 different categories. There is a multi-drug resistant TB and extensively drug resistant TB. Multi-drug resistance is resistant to only isoniazid and rifampicin, but in extensively drug resistant TB, it is resistant to the multi-drug resistance, that is isoniazid and rifampicin, but it is also resistant to one of the fluoroquinolones, like the betaquilin, or sorry, not betaquilin, one of the fluoroquinolones like moxifloxacin or sofloxacin, ofloxacin, or something like that. And then it is also resistant to the injectables, and injectables means there is betaquilin or there can be linezolid. So this kind of resistance can be there. And for the diagnosis, we use acid fast bacillus smear in microscopy. We can also use the culture, that is a gold standard for tuberculosis, and we can also use the gene expert, that is MTB RIF test. That is another name of gene expert, and it not only involves the diagnosis of Mycobacterium tuberculosis, but also the resistance towards rifampicin. So that is why it is a gold standard, because it is a rapid diagnostics test plus resistant test. The next topic that we are going to cover is non-tuberculous mycobacteria. These are also important because examiner might twist the question. because most of the times we are directly jumping, whenever we see the name mycobacteria, we jump toward tuberculosis. So this is not the thing that you have to do in the exam. Okay, the species are MAC, that is Mycobacterium avium complex. It involves the disseminated conditions in acquired immunodeficiency syndrome when the CD4 count is less than 50%. We already discussed this thing. Then there is also Mycobacterium kansasi, so that is responsible for pulmonary cavitary diseases, and Mycobacterium marinum. There had been a question, I don't remember the year, but there had been a question of FMGE on this one, Mycobacterium marinum. So it is a fish tank exposure. It is because of fish tank exposure. The next is about Indian context. So Mycobacterium kansasi, it is emergence in immunocompromised patients, like the patients who had acquired immunodeficiency syndrome or severe combined immunodeficiency disorder, Luskid and all those kind of things. And there can be a co-infection with Mycobacterium tuberculosis. So whenever there is a Mycobacterium tuberculosis infection, there are 23 to 30% chances that the patient might be having non-tuberculous conditions as well. Let's move towards the Mycobacterium leprae, that is also known as leprosy. There is a drug regimen for the leprosy, and you have to do it from the PSM because it is not extensively covered here. You have to remember all the drugs, you have to remember the color codes, you have to remember the dosage and everything very, very, very precisely in case of leprosy treatment. So do this topic from that section, because if I'll cover it here, then you will just skip it. So now that topic is left undone. You have to do it from PSM. Let's move towards the spirochetes. In spirochetes, there are 3 organisms, and those 3 organisms are highly important. We already discussed Treponema pallidum in syphilis when we were discussing sexually transmitted disorders. So in this section, we will just get a quick overview. The national history, like there are 3 forms. We already discussed primary, secondary, tertiary. So there is no any point in repeating it. For serology, we do RPR and VDRL, venereal diseases research laboratory, that testing, and then we match the values and see if it falls under that category. We also use the FDA-ABS assay and like a fluorescent treponemal antibody assay. We already discussed this as well, and lifelong positivity is there. And for treatment, we use benzathine penicillin G. Let's move towards the leptospira. In leptospira or leptospirosis, the features that are basically involved in this condition are biphasic fever. Biphasic fever means the fever peaks at 2 different intervals, but at the fixed interval. The next is about jaundice, which is there along with the pulmonary hemorrhage. So the prognosis directly becomes bad. Logically, it is a bad prognosis because there is a pulmonary hemorrhage along with jaundice. So this is not a thing that is good for patient, and it is difficult to treat. That's why it is a bad prognostic sign. Then the next is about, in Indian context, monsoon epidemics are related to the leptospirosis. There is a contamination of the water with the sewage because there is a contact of sewage water with the normal drinkable water sources. That is why there is increased cases in monsoon. Then there is also occupational exposure from farmers and cleaners. For diagnosis, we use culture. We use the blood for 1 week and urine for the 2nd week. And from the exam's point of view, you have to remember monsoon plus jaundice plus myalgia. If these 3 things are mentioned in the question, then it is a direct indication that the question is asking you about leptospirosis. So that can be the question referring to the diagnosis or treatment or anything. So you have to remember all those things. So this ends our section of spirochetes. Let's move towards the viruses and fungi. So the very first thing we are going to discuss in viruses is hepatitis. We all know that this is very high and important topic, not only from the exams point of view, but in general life as well. We are becoming doctors, and I am myself doing internship. So it is very important to know which are the vaccines that are must for healthcare practitioners, and this is one of those vaccines. I'll be telling you guys about the 4 variants of hepatitis virus, that is A, B, C and E. Hepatitis hepatitis D is also there, but that is not that important as compared to these variants. That's why I have not included that in these flashcards, but you can always go back to your notes and read more details about that type of hepatitis. So hepatitis A, we all know that it is a fecal-oral route, transmitted by fecal-oral route, and the treatment that we use is anti-HIV. IgM antibodies can be given in acute conditions, and immunoglobulin also induce to boost the immunity, and it is from the enteroviruses family. Then the next is hepatitis B virus. In hepatitis B virus, there is something called as surface antigen. You will be having questions which will mention the terms like HBsAg, HBeAg, or HBcAg, something like that. Or they can also give you hints like there is an antibody, or there is an envelope protein. So you must be knowing what these terms actually mean. So whenever there is S, it means surface antigen. Whenever there is E, it means envelope. Whenever there is C, that means core antigen. And when the patient is vaccinated, the patient will be having envelope antigen, but or surface antigen, but there will not be core antigen. Core antigen will be only present in those individuals who has active hepatitis infection. So this is applicable to only hepatitis B and C. Hepatitis B, C, and D. These three hepatitis, like A and E, are fecal-oral routes of transmission, but hepatitis B, C, and D, these three hepatitis has the transmission routes as sexually transmitted, vertical transmission, and post-transfusion transmission. In post-transfusional transmission, the most common is hepatitis C. So you have to remember this thing, and complications and all those things, you guys can just read it, because that's the ratta thing. The next thing is about HSV, that is herpes simplex virus. There are two variants, herpes simplex virus 1 and herpes simplex virus 2. The most common distinguishing factor is about lesions. Like if you know where are the lesions, you will be able to know which kind of herpes simplex virus is it. For example, HSV1, it is only limited to orofacial herpes and encephalitis is there. But in HSV2, there are lesions on the genital area, and there is more risk of vertical transmission, that is neonatal transmission. Of course, because genital areas are affected, they has the lesion, and whenever there is a delivery, let it be normal vaginal delivery or let it be cesarean section, there will be contact of the lesions with the skin of the fetus, and we all know that newborns are not that much immunocompetent, so that's why they will get infection. That's why vertical transmission risk is higher in HSV2. Let's move towards the diagnosis. For diagnosis, we use PCR, and we can also do lumbar tap, lumbar puncture, and then we can see if there is encephalitis, but only if there are symptoms. If there are no symptoms, we don't do lumbar puncture. Let's move towards the treatments. In treatment, in case of encephalitis or meningitis, for example HSV1, we use acyclovir, and if there is oral region or there is a lesion that is not having encephalitis or any other severe symptoms, then we can simply use valcyclovir or famciclovir. And in MCQ, they will mention things like there are vesicles, there is the patient is neonate, and etc, etc. So you'll have to think in the direction of HSV2, and if there is a mention of encephalitis or meningitis or anything like that, then you have to think about HSV1. Let's move towards the dengue arboviruses. So dengue is something that is extensively covered in PSM by your own faculties, but still I would like to have a small fraction from microbiome perspective. So in this flashcard, I have included a few things only. The dengue fever, as we already did the flashcards of the fever of unknown origin. In that one, there was enteric fever and there was dengue fever. So in this one, there is a sudden breakbone fever. We all know that breakbone means that's not actual fracture, but there is a myalgia, arthralgia, and that's why the patient feels like the bones are breaking and all that stuff, and that's why it is named as breakbone fever. There is severe myalgia as well. There are 4 serotypes. The second infection different serotype, that is dengue hemorrhagic fever risk. So that is you have to know. Then there is a severe dengue, that is dengue hemorrhagic fever is associated with it. Platelet count goes below 100,000. Hematocrit increases. We all know why hematocrit increases. If you don't know, let me tell you in short. What happens in dengue is that there is a breakage of blood vessels. When the blood vessels break, the plasma leaks out. When the plasma leaks out, automatically the blood inside the blood vessels gets concentrated, because RBCs are large in size and they cannot leak out. So of course, if plasma is leaking out, RBCs are getting accumulated, they will be concentrated, and therefore they will increase the hematocrit. That's why HCT is more than 20%. That is increased, elevated. The next is about plasma leakage, bleeding. That's what I already explained. The next is about shock. There can be a critical phase in between 3 to 7 days if the patient is left untreated. The next is about diagnosis. We can use NS1 antigen for the diagnosis, and we can also do the serology for IgM or IgG titers. Also, we can perform PCR. And dengue test is mostly done with along with the CBC, because if the fever is there, fever is persistent, the patient is having a body pain, myalgia, arthralgia, and all those symptoms. So the first thing that we tell the patient is do CBC and tell them to do the dengue test as well. The treatment includes supportive therapy, like there can be fluid therapy, transfusion if there is bleeding, or if there is very low platelet count and all that kind of stuff. So treatment is specific for that. Let's move towards the candida or fungal infection. We are entering in the mycology point from now onwards. There are only two topics. The first one is candida, the second one is dermatophytes. So in candida, there is candida albicans. It is a fungal infection. The diseases that it causes is oral thrush. We all know that there can be an image of oral mucosa having full thrush of white colored deposits. Don't confuse it with diphtheria, because diphtheria we have already covered in previous sections. So you should know how to differentiate between diphtheria and how to differentiate between candida. In diphtheria there will be pseudomembranes. In candida there will be oral thrush. You will be able to differentiate if you will go through various images. Okay, let's move towards the esophageal candidiasis. It is mostly related with the dysphagia, because the CD4 count is less than 100, and in oral thrush candidiasis the CD4 count is less than 200. We already covered the CD4 counts and related disorders in that HIV AIDS point, but still it is related to the fungal infections. So that's why you will have to remember these points as well. Then there is also vaginal candidiasis. Candidemia can be there, and we put central lines, and through central line the infection goes inside, and that spreads in the blood. That's why it is named as candidemia. The diagnosis is KOH mount, and like it's a budding yeast. So we can also see the pseudohyphae. So that's how you can differentiate it from the other fungal infections, because there are pseudohyphae and the other variants have hyphae, like true hyphae are there. Then for the culture we use chrome agar, and there can be green colonies. The treatment is basically for any fungal infection. What we use is systemically fluconazole we can use, itraconazole we can use, that are antifungals. And for topical use we can tell the patient to use cotrimazole and nystatin. So let's move towards the dermatophytes. In dermatophytes and ringworm infection, there are very few things that has been asked in recent exams. Already from the derma, there are only 2 to 3 questions every FMGE. So that's why this is the point where these two topics overlap with each other. Let's move toward the common species. So the Taenia rubrum is the common species. So what happens is that in Taenia rubrum there is Taenia corporis, Taenia curis, Taenia pedis, and the Taenia pedis is most common, because most of the times our feet are less hygienic, and that's where the fungus likes to grow. So this is what it is. There is M. canis, and it is animal. It is because of animal exposure. And then there is Taenia violacea. So it is related to India endemic. For diagnosis we use KOH mount. There can be branching septate hyphae. Like this is what I was talking about. There are septate hyphae in this, but in Candida there are pseudohyphae. So this is how you differentiate between these two conditions or these two organisms. Then we can also do the DTM culture. There can be color change to red if the culture is positive, and we can also do the Woods lamp examination. Actually, Woods lamp examination is used in so many things, so you have to go through it once, use your notes, because it will be given in much more crisp and detailed manner, and I would recommend you to use your notes only to read which color we see for which condition in Woods lamp examination. For the treatment, you can use topically azoles or creams can be used. You can also use terbinafine. And for the systematic use, we can prescribe griseofulvin or terbinafine for nails and scalp. And then we are moving towards the ultra high yield topics. Like these topics I'm not going to cover in this video because this is a kind of homework for you. I know it's not a time to give any homework, but there is nothing to tell about these topics because we have already covered alpha hemolytic and all those, rice water stool causes cholera and all those things. So this is what you have to go through quickly after reviewing all those topics. And then there are some tests, there are resistance patterns, and there are top 20 high yield topics which can, like the MCQs can be framed from. So you have to go through these topics as well. You have to read this ultra high yield section from this web application. So that's all for today. Thank you so much for staying till the last and watching this video. I hope it will be helpful, and I hope there will be lots and lots of questions from these topics. But these are literally high yield topics, and if you are unable to revise microbiology properly, then at least you have to finish these many topics. So at the end, I will again tell you guys the same thing. Very few days are remaining. Use your days wisely, use your time wisely, be selfish, even if it is something about your closest people or anyone that you care about, because these 15 to 20 days are completely yours and it will all be worth it. So that's all for today. Trust your source, trust your preparation, and have faith in yourself. Thank you so much for watching this video. Make sure if you like this video, then do like, share, subscribe, share it with your friends as well. Share it to as many people as you can, because who knows which topic will be there in the exam. So thank you so much again and have a good day. All the best.